Everyone, thank you. We'll get started in just a couple moments. Good morning, everyone. We'll get started in just a couple minutes. Good morning, and thank you for joining today's webinar, Threats to Medicaid. My name is Brandy Davis. I'm the Medicaid Policy Fellow at the Center for Community Solutions, and I'm honored to engage in this conversation with you today. At the Center for Community Solutions, we help make connections between people and organizations working to improve community conditions and quality of life for all of Ohio. We are a nonpartisan think tank with a main office in Cleveland, Ohio, and a satellite office in Columbus, Ohio. We focus on 5 health and services priority areas, one of which is Medicaid. Medicaid is a critical program that provides health care coverage to millions of Ohioans. Yet it faces significant policy threats, and today we'll explore what Medicaid is, the potential risks to its structure and funding, and how changes could impact communities all across Ohio. So today's focus is going to be on funding issues, policy shifts, and the resulting consequences, especially here in Ohio. As you know, Medicaid is a state federal program, and it plays a critical role for low-income and vulnerable populations. And any changes can have significant ripple effects on our communities. So let's begin with the basics. What is the current Medicaid landscape here in Ohio? So we'll look at the program and how it's structured and identify specific threats it faces, setting the stage for our discussion here. So to clarify, as I've sort of mentioned previously, Medicaid is a joint federal state program, and it provides health coverage for low-income individuals. It's funded by both the state and our federal government, and it's administered here in Ohio by the Ohio Department of Medicaid. So there are 4 major threats facing Medicaid, and we'll discuss those here today. These include work requirements, per capita caps, block grants, funding cuts related to the FMAP trigger, and then also that trigger language. Each of these can potentially reshape how Medicaid operates and who ultimately receives the care that they need. So first up are block grants. These are a form of grant and aid where the federal government provides state and local governments a fixed amount of funding to address a broad set of needs, like community development and public health. While proponents say these provide more flexibility and fewer administrative conditions, what we know is that block grants really mean fewer dollars over time, which can mean less funding in times of high need. So next we have per capita caps. Under this model, federal payments to states would be capped on a per beneficiary or per member basis rather than being based on the actual costs. And that's how Medicaid operates today, on the actual cost of care. Ohio would receive a fixed amount per enrollee, regardless of the increasing cost of care. Another significant policy proposal is work requirements. And we've recently submitted a waiver. We'll talk a little bit more about that in a moment throughout this presentation. But these proposals would tie Medicaid eligibility to employment or community engagement, which might result in coverage losses, particularly among vulnerable working adults who may struggle to meet these criteria. So lastly, we have proposals to reduce the federal medical assistance percentage, or the FMAP. FMAP is essentially a share of the Medicaid costs covered by the federal government. It's calculated based on each state's income relative to the national average. By law, there's a floor where the FMAP cannot fall below 50%, but the FMAP changes, especially for Medicaid. Any FMAP changes, especially for the Medicaid expansion populations, could dramatically shift costs to states. So all of these proposals put several groups at risk. We're talking about low-income families, children, older adults, people with disabilities, and those working adults in low-wage jobs. When funding is cut or policies become too rigid, it leads to delays in care, worsening health disparities, and increased financial instability. Beyond individual risk, reduced Medicaid funding can create broader challenges for our healthcare system. Community health centers, rural clinics, and safety net hospitals really rely heavily on Medicaid reimbursements, and any of those cuts can force these providers to reduce services or even close, leading to an economic ripple effect and ultimately a deterioration in overall public health. So let's zoom in on one specific policy change, Ohio's 1115 Medicaid work requirement waiver. So how will these changes affect Ohioans? This waiver aims to demonstrate the impact of linking Medicaid eligibility directly to work, specifically among Group 8 beneficiaries, which are those able-bodied working adults. So let's delve in. Group 8 includes about 770,000 Ohioans who expanded Medicaid coverage under the Affordable Care Act. This group is comprised of able-bodied adults between 19 and 64 with incomes up to 138% of the federal poverty level. In Ohio, the waiver specifically ties Medicaid eligibility for those Group 8 beneficiaries to work requirements. This means that to remain eligible for Medicaid, individuals must meet certain employment or community engagement criteria, and it's subject to specific exemptions, though, and there are some reporting rules. Ohio's demonstration waiver is designed to identify individuals through data available to the state already, and it should, in theory, exempt any individual who is over 55, is already working, is already in job training or school, or is participating in an alcohol and drug addiction treatment program, or cannot work due to underlying mental health, substance use, or medical conditions. So Ohio's waiver sets a fixed work requirement for those Group 8 populations that we've identified, though we must also consider the administrative process and several potential federal changes. So let's get into those. So we'll talk about the timeline for the Medicaid work requirement. So this slide essentially shows a timeline of some important developments in the work requirement waiver process, and it helps us to understand the historical context and where we stand today. We can see in December 17th, the Ohio Department of Medicaid posted the public notice indicating that 30-day public comment period had begun on January 21st, 2025. Due to advocacy, that date was actually extended for public comment, and it ended at 5 p.m. The first of two hearings was held on January 3rd. The second hearing was held on January 9th. And then the state's Group 8 1115 demonstration waiver that incorporated the feedback from those public hearings was submitted to the Ohio Department, was submitted by the Ohio Department of Medicaid on that date. And so now we know that the target implementation and really the development, if it's approved, the development of, yes, all April 7th, the federal comments are due. That is correct. The target, and we'll talk a little bit more about when the federal comments are due. I've got that in the end of the slide and also a link for everyone. The target date for implementation of the work requirement statewide is January 1st of 2026. So let's talk about some key features of the waiver. Beneficiaries can count certain unpaid activities like volunteer work, internships, community service, or caregiving as qualifying work if documentation is supplied. However, the requirements are quite strict. Individuals must meet one of the several criteria that we mentioned, being over 55, being employed, those types of things. And we talked about how for the work requirement, we're looking at January of 2026 for that implementation. And individuals who apply for the Medicaid on or after the date of January 1st of 2026 will be notified through the application process that they qualify for Medicaid or are ineligible for Medicaid, and they'll be evaluated under the new requirement at their next eligibility renewal. For those new Group 8 eligibility requirements, it's also important to note that within 6 months after the implementation of the demonstration, Ohio must hold public forums. So this is important for advocates to know that you will have an opportunity to weigh in on the progress of the demonstration program. And it allows stakeholders to really provide comments, and those comments will be included in the quarterly reports along with the annual report that's sent to CMS. So public input, again, has been very vital. We talked about that 30-day comment period. And then also we'd like to point out that stakeholder feedback is an important part of shaping these policies. And the federal comment period closes on April 7th, 2025. And we have a link to access that comment period in our presentation at the end. And this presentation will be sent out. We'll be able to access it after this webinar is ended. So at the Center for Community Solutions, we've been tracking these developments closely, analyzing how these policy shifts might impact local communities. Another important element is how Medicaid work requirements will be tracked and reported. According to ODM's final 1115 work requirement waiver submission, the details of work components, including tracking of outcomes, will be defined in the implementation plan. And so we've seen implementation plan is a big part of this, and we don't have access to that implementation plan just yet, but we know that it's in the working. So the tracking of the data and the role of the managed care organizations or MCOs will be defined in the implementation plan. This demonstration will use data to identify individuals who meet one or more of 5 pre-enrollment criteria, and that's that criteria that I mentioned before. There will be no regular reporting by enrollees. Individuals with households of earned income will be presumed to be employed. Individuals who have applied for are already enrolled in another program that has a disability as a basis for enrollment will also have presumptive eligibility to have intensive physical or mental health status, right? So individuals who qualify under another eligibility category will essentially be exempt. So who must comply with these work requirements? So most Group 8 beneficiaries between 19 and 55 are required to meet them unless they're exempt. Exemptions apply to those over 55, already working, enrolled in job, training, or school, participating in treatment programs, or those who are unable to work due to serious health conditions. So while people with disabilities should be covered in this category, people with undiagnosed disabilities or health conditions with which they struggle to address but fall short of government definitions of disability will likely be impacted. In addition, low-wage workers, parents, or caregivers may also struggle to meet the work hours, risking losing their Medicaid coverage. According to Ohio Department of Medicaid's final 1115 waiver submission, this demonstration will use data to identify individuals who meet one or more of the 5 pre-enrollment criteria. There will be no regular reporting by enrollees. Individuals with household earned income will be presumed to be employed. Individuals who have applied for or are enrolled in another program that has a disability as a basis for enrollment will be presumed to have intensive physical or mental health status. and individuals who qualify under another eligibility category will also be exempt. So, furthermore, we know that residents in rural areas face unique challenges, oftentimes due to uh, limited access to jobs, sometimes temporal jobs, limited access to transportation. And while those who have chronic health conditions, they simply may also not be able to comply with the requirements due to their chronic health conditions. And research from the Center on Budget and Policy Priorities suggests that if these policies are fully implemented, Medicaid could end for millions of Americans, Ohioans included. Recent reports indicate that a significant number of individuals are at risk of losing coverage because of these work requirements. Even those engaged in qualifying activities might face barriers in reporting their work status. So this chart just illustrates some of our work at Community Solutions to gauge the impact of work requirements by county. To see more, you can use the link in the slides. Again, the slides will be posted, and you can access the full chart that contains all counties across Ohio. Now, looking at disenrollment data, we see that many Group 8 members, despite working in low-wage or unstable jobs, face significant challenges meeting the necessary hours, or they could, as is illustrated by the implementation of work requirements for this population in other states, such as Arkansas. The inability to manage the logistical barriers often leads to unexpected coverage gaps. So that's something as advocates that we want to really keep an eye out for. People who lose their Medicaid coverage due to these policy changes are likely to experience worsening health outcomes, more emergency room visits, and untreated conditions, which could lead to a broader public health crisis. To mitigate these risks, one solution is to expand support services. This includes providing transportation, job training, childcare, and more flexible exemptions for work hours, which can really help people who are covered. Some policy adjustments are also needed. For example, Ohio may need to broaden some exemptions to protect those in caregiving roles and improve reporting systems to reduce the administrative burden in both applicants and providers. So while Ohio's work requirements aim to promote employment and self-sufficiency, they also have some potentially negative impacts on certain populations, like low-wage workers. Ongoing evaluation and adjustments will be essential to ensure that these policies do not harm our communities. What we are describing and will continue to discuss throughout this webinar would be considered as funding cuts to the Medicaid program. Each of these is a funding cut, essentially. So let's dive in a little bit deeper. So let's shift our focus to another funding mechanism, per capita caps. We'll explore what these caps are and how they differ from our current Medicaid funding structure. A per capita cap sets a flat, preset payment per Medicaid enrollee. Unlike current funding models based on actual cost, this approach dramatically reduces federal funding by imposing a fixed amount per person. As you can see from this graph, the model limits the growth of funding strictly to enrollment numbers without accounting for rising service costs. So as service costs increase, that per member, per head, or per beneficiary cost remains the same and doesn't adjust for those increases. Under this system, the federal payment is calculated per head using a preset formula. While states receive an additional fixed amount for new enrollees, this method doesn't cover increased costs related to medical technologies, public health emergencies, or an aging population. There are serious challenges with per capita caps. Initially, the allotment is often underestimated. Plus, annual increases are based on a preset growth index, which is typically slower than the rate of the rising healthcare costs, which leads to a growing funding gap over time. And it's just not manageable, frankly. Ultimately, per capita caps shift billions of dollars in costs from the federal government to the states. This could force states to make difficult decisions about eligibility, services, and provider payments, particularly impacting older adults, people with disabilities, pregnant people, and low-income children. Now let's discuss block grants and how they would affect the Ohio Department of Medicaid's ability to serve Ohioans. A block grant is a financing mechanism that dramatically cuts Medicaid funding by shifting federal payments from covering actual costs to a fixed, preset amount per state. This means that funding isn't adjusted based on real-time service or needs. Under a block grant system, the federal government provides a fixed payment per enrollee based on a formula. And we'll discuss that formula in just a moment. There are no additional funds if enrollment increases or if there is an increase in services or service demands, even in the face of unexpected events like hurricanes or economic downturns. You just have to work within the confines of the preset amount provided under the block grant system. And here's another similar graph, but this time applied to block grants. It illustrates the limited fixed nature of block grant funding. Like per capita caps, block grants come with their own set of challenges. The initial allotment is often set too low, and the annual growth is insufficient compared to the actual healthcare costs that continue to increase, and it leads to a compounding funding loss over time. And so I would like to remind everyone if we will be sure to answer questions. So if you could hold your questions or either put them in the chat, and we'll answer those questions at the end of the presentation. So the consequence is a significant federal cost shift to states. As expenses outpace these fixed payments, states may be forced to cut services, undermining comprehensive Medicaid coverage for the most vulnerable populations. Now let's talk a little bit more about funding cuts related to the Federal Medical Assistance Percentage, or the FMAP, and reductions in Medicaid expansion support. Is essentially the federal match rate for Medicaid costs. For expansion populations under the Patient Protection and Affordable Care Act, or the ACA, the federal match is currently around 90%, meaning the federal government covers 90% of the cost for eligible adults. In traditional Medicaid, states with lower per capita incomes receive up to about 77%, while higher income states get at least 50%. Under the expansion rate, the rate jumps to 90%, which is critical for keeping the cost manageable. If FMAP rates are reduced, even slightly, it means that states have to pick up a larger share of the cost. For Ohio, a drop from 90% to around 65% could mean a much heavier financial burden and an immediate risk of coverage loss for many expansion enrollees due to the trigger language. The expansion of Medicaid under the ACA has been a cornerstone of Ohio's public health strategy, extending coverage to hundreds of thousands of low-income residents who otherwise would not have had access to health insurance. However, recent federal changes and these proposals to roll back aspects of the ACA expansion, potentially reducing federal matching funds. For instance, the population that gained access to Ohio Medicaid through an expansion of the federal poverty level up to 138%, often referenced as the expansion population, the federal match would decrease from that 90% to Ohio's general matching rate of around 65%. Under 90% FMAP, the federal government covers most costs, leaving the state responsible for only 10% of the share of Medicaid costs. Decreasing this to 65% means the state would now fund 35% of the share of costs for the Medicaid program. And while this would still mean that Ohioans would get $1.84 in health services for every $1 the state invests in Medicaid, which is substantial, It's hard to ignore the impact this decrease in funding could have on Ohio's budget. This increased share could strain Ohio's budget, forcing the state to allocate more funds to Medicaid or to reallocate money from other critical services. Reduced federal funding might prompt the state to lower reimbursement rates to providers or to delay payments. This could discourage providers from accepting Medicaid patients, leading to fewer available healthcare services, especially in rural or underserved areas, and potentially worsening health outcomes for the expansion population. According to Governor Mike DeWine's 2026 2027 state budget proposal, and I quote, if the federal medical assistance percentage for medical assistance provided to members of the expansion eligibility group is set below 90%, the Department of Medicaid shall immediately discontinue all medical assistance for members of the group. If the medical assistance percentage for medical assistance provided to members of the expansion eligibility group is set below 90%, the Department of Medicaid shall discontinue all medical assistance for members of the group. Rollbacks of Medicaid expansion categories, currently at 138% of the federal poverty level, could reverse the gains Ohio has made in reducing the uninsured rate. For many Ohioans, particularly in rural areas, such challenges would mean losing access to critical health services and facing higher out-of-pocket costs. So trigger laws come into play when federal support falls below a certain threshold. Currently, 12 states have such laws, and in 9 of them, even a small FMAP drop below 90% could automatically result in the end of the expansion coverage. And while Ohio does not currently have a trigger law per se, if the current language remains in the budget as it is currently written, we would essentially become a trigger state. Under the ACA, Medicaid was expanded to nearly all adults with incomes up to 138% of the federal poverty level. However, a Supreme Court decision made this expansion optional, which adds another layer of complexity to the debate. The federal medical assistance percentage is a share of Medicaid costs covered by the federal government, as we've discussed. And under the ACA, states that expanded Medicaid, like Ohio, now receive a 90% federal match rate. This is important to reiterate because current federal proposals to reduce the FMAP rates would then shift those costs to the states. It would limit funding for the expansion populations, and that frankly would threaten coverage for thousands of Ohioans because of the reasons we've been describing here today. Medicaid expansion has significantly increased coverage in Ohio. If federal funding is reduced, the state may have to cut eligibility or benefits, leading to more uninsured individuals and higher uncompensated care costs for hospitals. So we talked about the trigger laws that several states have. And this map illustrates the two defined scenarios. So one, states where Medicaid expansion quickly ends should federal funding of the FMAP fall below that 90% for the expansion population. And two, states where Medicaid expansion would likely be reduced or eliminated through a review process should federal funding fall below, which is federal funding meaning the FMAP, if it were to fall below that 90%. So in response to these sweeping changes, states and national groups are mobilizing to protect Medicaid coverage, especially for older adults and children who are linked to those expansion groups. Advocates are calling for a more balanced approach that maintains that robust federal support while avoiding drastic budget cuts. I encourage all of you to get involved and submit public comments during the ongoing federal public comment period. And so here's just a slide to the federal public comment period. Again, these slides will be available, and you can click the link here to access the federal public comment period and sort of let your voice be heard. That brings us to the end of the presentation. Now we'd like to answer some questions from our attendees.
Randy, thanks for that great presentation. I'm Tara Britton. I'm the policy director at Community Solutions, just sort of helping on the question side. And we had for a moment the chat and the Q&A going. And so I don't know if you want to scroll up in the chat a bit. There are a few questions in there and then
Okay.
switch over to the Q&A.
Okay, and then also, just for time permitting, we can also sort of answer some of these questions too if you have to run, or if we don't get to a few of them, and post them on the landing page as well. Just scrolling up. So I'm just saying that some comments were due. Marie Curry asked, do you mean that people will not have to prove their compliance until their first redetermination? So Marie, it's not proving compliance. Redeterminations generally are about making sure or making certain that you are still eligible. So individuals, again, that after the January 1st, 2026 implementation, upon their redetermination, they will be looked at or examined based on the new criteria. You know the percentage of the 770,000 that would be exempt of the work requirement. We do not have numbers on the percentages. We are, however, and I hope that you remain connected to us because we are looking into just some overall options relative to some county level data and some fact sheets. So we'll be producing those soon. So hopefully you can stay connected to us um, and be on the lookout for that information.
Thanks, Brandy. I think that's everything from the chat. If you want to switch over to Q&A.
Sure.
Some I
Yeah, and
was
so
able to answer throughout, but there are a couple new questions in here.
Sure. So what do you make of the comment submission process not being located on regulations.gov? One impact that the comments are not publicly accessible. So I think, and that's one of the things that, we've got to stay connected as advocates, just to make sure that we are sharing this information and making sure that they are being accessed by our networks and everyone that we can. And so we work definitely at the Center for Community Solutions to share the information with as many people as we can. So we have another question. If the state budget is enacted as currently written, do you know if additional funding for the state BCMH program is proposed? So I am not aware. And the slides will be available. I would like to make certain that we say that. So Ohio received a significant number of comments pertaining to the work requirement that indicated citizens do not support them. What else can we do to hold our state officials accountable to the public? We can always contact our state officials, right? As constituents. I would encourage you to contact your state officials as constituents to make your voice be heard. And to just sort of communicate with them and let them know how you feel about the work requirements. In addition, though, there were some changes. The Ohio Department of Medicaid did implement a lot of the processes and changes into the work requirement that was actually submitted, the final version. So they are listening as much as possible. All right, and I see we've got Tom Olsted has his hand raised. Tom, can you type your question in? So are advocates looking to get the trigger down to another level, or is it a better strategy to just oppose the trigger? So one of the things that we are examining is just sort of having a balanced approach. So really that there've been several strategies, frankly, and I've been speaking with some people nationally, some Medicaid coalitions, and we've developed or reinvigorated a Medicaid coalition of members that was really effective in ensuring Medicaid expansion did happen. And so we're looking at several strategies right now, not just one. So I cannot speak to the implications for a higher rise at this point. There will be more information coming out in the implementation plan. So how do we stay connected? I would encourage everyone to sign up for our 5 things at communitysolutions.com. You can go to communitysolutions.com and scroll down to the bottom of the page and click on 5 things. And that would be a wonderful way for us to stay connected. And we'd love to have more things coming to your inbox every Monday morning. We'll have articles following this and other issues that are affecting Ohioans. Question, if you could put that question in the Q&A, if you could type it, we'd greatly appreciate it. So I'll give another couple minutes for questions. We've answered the majority of them. So we appreciate everyone's participation in today's discussion. Medicaid remains a vital program for Ohioans, and the proposed changes could have far-reaching consequences. To stay informed and advocate for Medicaid protections, remember to visit communitysolutions.com. Thank you so much for participating in our webinar today. It was great to have this discussion with you, and I hope that you have a wonderful day. Take care, everybody.